Good evening and welcome. I'm James Liu, and I'm a librarian at Stanford Health Library. Thank you for joining us for our talk tonight entitled Advancing Toward Precision Medicine in Childhood Inflammatory Bowel Disease. It's my pleasure to introduce our speaker, Dr. Michael Rosen. Dr. Rosen is a pediatric gastroenterologist and physician scientist here at Stanford, and the director of the Stanford Center IDB Celiac Disease. He has been inflammatory bowel disease research since beginning training 20 years ago. Throughout the talk, please enter any questions in the Q&A box at the bottom of the screen. And at the end of the talk, Dr. Rosen will answer as many of them as possible. Over to you, Dr. Rosen.
Thank you, James. Well, I'm really excited to be here and was excited to get this invitation. So thank you all for having me and for joining tonight. You know, food is supposed to be for joyous occasions. It's supposed, we gather around food, we celebrate holidays with food. We gauge milestones with food. We get together with friends around food. But what if food, rather than bringing joy, brought discomfort? What if food brought fear of being tied to a bathroom such that you don't want to leave the house? And this is the challenge that many of my patients face every day with inflammatory bowel disease. And what motivates me to do better by children and young adults facing the challenges of this disease. So let me walk you through the journey I'd like to take together today. And give me 1 second, I'm having some trouble with this pointer. Let's see if that. All right, we'll work through it. Pardon me. So this is the journey I'd like to take together today. I'd like to take some time explaining what is inflammatory bowel disease. I'd also like to move to introduce you to our new Center for Pediatric IBD and Celiac Disease, which launched this year in March. And I'll take a moment now to say that although our center does cover inflammatory bowel disease or IBD and celiac disease, but the talk today will be focused on inflammatory bowel disease. And then I'd like to share 3 research stories from our group that show how we're working towards precision medicine in childhood IBD. One on precision dosing of medications, one on how we're learning how to use gene expression to predict response to those medications, and one on how we're using new cellular approaches, specifically organoids or mini guts, I'll explain this further later, to model the disease and advance precision medicine. So let's all get oriented to the digestive system here. Hopefully you can see my red pointer. But here you see an image of our digestive tract, which runs continuously from our mouth to our anus, beginning with the esophagus above the stomach and the stomach. And then the stomach's followed by over 20 feet of small intestine that absorbs most of our nutrients and water needs. This last part of the small intestine is going to be relevant. It's called the ileum, which feeds into the colon, which is also sometimes called the large intestine, which makes this sort of U-shaped path around our abdomen and ends with our rectum, which is really the sort of last part of the colon. And the colon absorbs some of our water needs, It holds much of our microbiome. It's very microbial dense, and it is a place where those microbes can ferment foods that aren't digested in the small intestine to metabolites that can be absorbed. So there are two main forms of inflammatory bowel disease in both children and adults. The first one I'll mention here is ulcerative colitis. Ulcerative colitis, as the name indicates, is generally limited to the colon or large bowel. And it can involve just the lower part of the large bowel and be called left-sided or distal colitis, or it can involve the entirety of the large intestine and be called pancolitis. And then the other form of inflammatory bowel disease is Crohn's disease. Crohn's disease, distinct from ulcerative colitis, can occur anywhere from the mouth to the anus, so really anywhere in the digestive tract, but typically involves the last part of the small intestine called the ileum, like we discussed in the previous slide, and the colon. And it's a little different also from ulcerative colitis, that instead of it being a continuous inflammation, you can get these skip areas that are demonstrated in this diagram. And I think to give you an idea of the seriousness of these diseases and how much discomfort and difficult symptoms they can cause, giving you a look, the same look that we as gastroenterologists have through our endoscope, where we can look inside the intestine, will give you a good idea. So I'm showing you a picture of a normal, healthy colon. You see reflections of light glistening against healthy, thin mucosa. You see these nice, delicate vessels underneath the lining. This is what a colon should look like. Now I'm showing you a picture of a colon with severe ulcerative colitis. You see it's a very different picture here. There's bleeding and really loss of all features. You can imagine how this just does not work and can cause very difficult symptoms for patients. And this is a picture of a colon in a patient with Crohn's disease. It's a little different from ulcerative colitis, where you have these deeper ulcerations. This is what we call a linear ulcer here, but they can be right next to an area of normal lining of the bowel. So inflammatory bowel disease really came on the rise after it was first recognized really in the 1800s, at least ulcerative colitis. Crohn's disease was coined in the early 1900s. And with the Industrial Revolution, increased dramatically in incidence in Western countries. Until about now, where in adults it's somewhat plateauing in Western countries, but now we're seeing a rise in newly industrialized countries, in particular China, India, that's continuing. But even in Western countries, the rate of childhood inflammatory bowel disease is rising. So 25% of patients with IBD are diagnosed under 20 years of age. And there are about there's probably more, but through insurance claim studies, our estimate is that there's 60,000 children with inflammatory bowel disease in the United States. And as I said, the incidence in children is rising, and particularly in the youngest children still. And this is still poorly understood. So the rapid rise in inflammatory bowel disease in the last century really goes against the idea that this is purely caused by genes. Human populations don't change their genetics that quickly. But we do know that this is in part a genetic disease, that patients clearly carry genetic predisposition that's complex. And so I'm paraphrasing the naturalist E.O. Wilson by saying here, genes propose and the environment disposes. So I think that's also the case for inflammatory bowel disease, where you have a genetic predisposition over the course of one's life in a genetically a person who has genetic risk. They're exposed to environmental triggers, which I'll review some of the thoughts on the next slide, but I'm putting in this image antibiotics as one that's been implicated. And the ensuing changes over the course of time, the interaction of the genes of the environments leads to a situation of chronic intestinal inflammation. So similar concepts reflected in this slide, where again, we start with a genetic predisposition, but various factors over the course of a lifetime and factors that have changed with industrialization likely contribute to the onset of IBD. So whole foods, fish, and the good oils in fish, these are likely positive factors. Exposure to farm animals and even domesticated animals likely protect from inflammatory bowel disease. But then you get into more negative exposure: cigarettes, antibiotics, potentially other medications, processed food, foods high in saturated fats, concentrated sweets. And these things collectively likely contribute to a change in the microbiome, the microbes that inhabit our bowel, that's associated with Western society, that interacts with the inside of our intestine and our immune system to, in some patients, promote chronic intestinal inflammation and inflammatory bowel disease. So what do I mean when I say intestinal inflammation? And I want to show you on this slide. And I don't want you to look at all the details on this slide, but I'm going to point out a few features. So this slide shows a diagram of the lining of the intestine. So I'm tracing here the inner lining of the intestine, also called the epithelium. And in a healthy state, there's this single layer of cells that separates our immune system below from food products and bacteria on the inside of our bowel. So where I'm pointing here is the inside of our intestine. But there's this peace agreed upon between our immune system and the bacteria in the healthy intestine. There is a thick mucus layer lining the intestine that prevents those bacteria from penetrating. There's an intact lining of the bowel. There's lots of these cells marked with a G called goblet cells, which make the mucus. And the lining of the bowel also makes proteins that sort of help control the bacteria, called antimicrobial products. And the immune system's surveying, checking things out, but only getting activated when there is a disease-causing microbe that gets inside. However, in inflammatory bowel disease, there are lots of changes we see with inflammation, including a change in the composition and numbers of the bacteria lining the bowel and the products that they create, a loss of the ability to control those bacteria because there's a thinning of the mucus layer, allowing those bacteria to get closer to the lining of the intestine, fewer mucus-producing goblet cells. And this leads to penetration of bacteria and activation of the immune system, sometimes inappropriately, to create a lot of inflammatory products. And one that we're going to talk about is cytokines. And cytokines are, I often tell my patients, they're inflammatory hormones that tell different parts of the intestine and body to sort of activate inflammation in many instances. And the last part that I didn't mention is that there's breakdown in this lining such that there's sort of tears or gaps and you get leakiness of in both directions across the lining of the bowel. So that's the very quick introduction to inflammatory bowel disease. And I'd like to now discuss a little more about what we're trying to do about it, and particularly in children. So we are very fortunate to have received a transformative philanthropic gift to support a Center for Pediatric IBD and Celiac Disease here at Stanford. In this slide, I'm going to explain to you how we're planning to build that out and building the foundation of this center. So, of course, it has to start with patients and clinical care. And we are in ongoing recruitment of additional faculty. We are expanding interdisciplinary care, expanding technology to help with monitoring of disease, and investing in training and patient education on the clinical care side. And then the other side of the spectrum, research. We are also recruiting faculty to advance research in IBD and celiac disease. We are thrilled to be able to offer through this gift a seed grant program and research training awards across the university, and I'm going to give a little more information on that. But then really to make this all work and to drive the engine of discovery is connecting and involving our patients in research. And this means inviting them to participate in research studies, including those that allow for the safe collection of tissue samples, stool, blood, to study what's the processes that are leading to chronic intestinal inflammation, the microbiome, the immune system, to have access to data to understand outcomes. And we'll be supporting staffing and all the storage and data needs that are required for such an undertaking. So this is the three-part strategy for building our Center for Pediatric IBD and Celiac Disease. So for a parent and a child with inflammatory bowel disease, it can be very challenging to find all the types of care that are needed. It's not just finding a gastroenterologist like myself. Children with IBD need direction on nutrition. They need direction on navigating pharmacy and medications and prior authorizations and education around medications. They need help with school due to disability related to the disease and other psychosocial factors, like help with pain management, help with easy access to advice when their child has symptoms. And last but certainly not least, mental health support, because the incidence of depression, anxiety, disordered eating with IBD is certainly higher than in the general population. And so what I'm very proud that we're able to do is provide whole patient care within one center now and bring some Zen relaxation to families. And, you know, with a dietitian, a pharmacist, a clinical psychologist, a social worker who's a licensed therapist, and expert nurses and nurse practitioners focused only on IBD and celiac disease, all under one roof. So families can get the complete care they need by this really remarkable team. And on the research side, before this center, Stanford certainly had all the strengths and all the right disciplines related to pediatric IBD and celiac disease. We have exceptional microbiologists and microbiome scientists. We have tremendous strengths in immunology, the study of the immune system, and particularly human immunology. Some of the best engineers, chemists, molecular biologists, data scientists, and clinicians, but nothing really uniting these folks around these disorders. And so I think this is what the center can bring to Stanford. We're able to galvanize the expertise of the scientific community here around pediatric IBD and celiac disease. And so One of the primary ways we're doing this, and we're super excited about this, is through center grants. And I'm proud to say the center has awarded 17 Stanford investigators so far, with a total of $2.5 million in seed grants and research training awards, all around pediatric IBD and celiac disease. And I'm not going to go through each one today, but these are some of these are at least the seed grant funded investigators. And you can see the incredible diversity in disciplines and other attributes around these investigators: microbiome, organoids, biologic therapies, immunology. So this is very exciting and bringing a new unity on campus around these diseases. So I'm going to conclude there with a description of the center, but I think you can probably see why I'm so excited about it, and move to a few research stories. And these mainly derive from work that my group has done before Stanford. I didn't tell you earlier that I moved here a year ago from Cincinnati and Cincinnati Children's Hospital, but that we're certainly continuing and moving forward here at Stanford. So I'm going to talk a little bit about how we can optimize and personalize drug therapy in pediatric IBD. And to do so, you have to understand how some of these drug works. So I mentioned about these inflammatory cytokines or inflammatory hormones. And one of them that really is central to driving inflammation in IBD is TNF, or tumor necrosis factor, but we'll call it TNF. TNF causes activation of immune cells, tissue destructions, death of cells in certain parts of the body, including the lining of the bowel, and leaky gut or permeability of the bowel. And drugs, biologic drugs that block TNF really transformed care and outcomes for children and adults with inflammatory bowel disease. And they first came out in the late 90s. And so by blocking TNF, we can reverse these processes and help resolve inflammation in many, unfortunately not all patients, but in many patients. Certainly was paradigm shifting for the treatment of the disease. So how well does it work? Well, what we found and what companies consistently do in drug trials is they determine through phase 2 studies what a good dose to test will be. And they end up with an average dose of a drug, in this case, an anti-TNF drug, that perhaps inevitably results in what might be called average outcomes. And so this is a diagram of the rate of clinical remission, meaning basically having no symptoms at a year in children after being treated with infliximab, and that's an anti-TNF drug. And, you know, it was a good rate, 55% were in remission. But if you take the glass half empty approach, there's still 45% of children treated with this drug who are not served, at least by standard, quote unquote, average dosing. So let's talk a little bit about the drug dosing. So I'm going to show you a graph here, or kind of a diagram of a graph. On this y-axis, we have the drug level in the blood, and on the x-axis, time. And each of these red lines are a dose given of an anti-TNF drug over time. And what you can expect to see when you do this, and this is how the drug is given, is you get a large level of the drug in the body, in the blood, after the dose is given. And then over time, it slowly gets cleared from the body until you give the next dose. And when we do it this way, our hope and goal and the plan is that the drug remains in the system. It never goes quite to zero before they receive the next dose, and then so that they always have at least a minimal exposure to the drug. So this is ideal. But with average dosing, we find that we far short of ideal in many patients. And what happens for some patients, that happen to process the drug differently than others is that the drug is cleared after doses much quicker and falls sometimes all the way to zero, well before the next dose is given. And so in these patients, they have gaps in exposure, and that can lead to worse outcomes, worse effectiveness of the drug. It also can lead to the drug not working for them long-term for reasons I won't have time to get into today. So we recognize that you could measure levels of drug in the body, and some people before me had seen that levels seem to correlate with response. And so we decided when I was at Cincinnati Children's to, in our own practice, develop internal guidelines to monitor drug levels in a proactive way and optimize the dose accordingly. So we, this way, make sure we have at least a minimum level of drug in our patients. And even if they were doing well, if the level was too low in our estimation, we would bump the dose up a little bit to make sure we got that minimum level. And so we did not take a randomized study approach to this, which is sort of the gold standard, but instead made a practice change and systematically studied it in a improvement science-based approach. And so we did a large practice there. We educated our providers. We distributed these guidelines. We posted them online where they'd be available to everyone to refer to. And then we incorporated recommendations into the way we order the medicines and certain planning meetings we had around the care of our patients so that it became part of the system that we were monitoring these levels. And by doing this over the course of about 4 years, we were able to dramatically increase the rate of sustained remission after instituting this drug monitoring guideline. So we increased it, as this graph shows here, by 17.5%, or from 41% to 60%. Now, this is actually a much more stringent outcome than the clinical trial I showed you. And so, you might say, well, that's not that much better than 55%. But it actually is, because we're looking at patients not being well in just a snapshot in time, but actually over an entire 6-month period. And so this was a dramatic improvement. And although we were comparing patients treated at a later time point to those treated at an earlier time point, and that has its drawbacks, we did make every effort to control to make sure the patients we were comparing were similar and that the effect was most likely related to this intervention in our practice. And this was led by a trainee of mine, John Lyles, in pediatric IBD, and an adult GI fellow at Cincinnati, Aditi Mulgoon. And so actually now, with this study and others, it's fairly accepted practice for us to do this kind of proactive drug monitoring. And I'm absolutely convinced it's leading to better outcomes for our patients. So another area where we were very interested in optimizing drug therapy was in more severe pediatric colitis, or what we call acute severe colitis. These are children hospitalized for very bad disease. So they're severely ill. They might require blood transfusions due to loss of blood in the bowel. Unfortunately, historically, even when treated with when they get to the point they're treated with one of these anti-TNF drugs, historically, the colectomy rate, meaning the rate at which the only option is a surgery to remove the colon, is 50% at a year. And this is with using what I described as sort of the average labeled dosing for anti-TNF drug, infliximab. And we recognize that these patients may have much higher anti-TNF clearance, meaning the drug may move through the body much faster due to the severity of the disease in these patients. And so to study this, I worked with another clinical fellow trainee, Caitlin Whaley, on a multi-center study. This was 7 centers across the United States, where we enrolled patients in the hospital with acute severe ulcerative colitis, treated with an anti-TNF biologic drug, infliximab. One of the first things we noticed in this study is that practice was getting ahead of the science a bit, and all the providers were all actually using higher doses than we'd seen used in the past. So that's one thing to keep in mind here. But we followed these patients closely, especially while they were in the hospital, and we did serial measurements of the level of the drug in their body, as well as looking at labs and clinical factors. And we can work with our clinical pharmacologists to do modeling of how the drug goes through their body, and look at what factors predict that in a patient, such as their labs or their weight, and develop really accurate models for predicting how a drug will move through the patient's body, or the term for that is called pharmacokinetics. And we found that 71% of patients responded to the drug at day 7, early response. And actually, at this early time point, there was really no association between how the drug moved through the body and the response, which led us to believe that actually these higher doses were overcoming any problem with the pharmacokinetics. And then as we got out to half a year, week 26, we found that the remission rate was 43%, which, considering how severe their disease was not so bad. But what was more surprising was that the rate of needing a colectomy or surgery to remove the colon because medicines had failed was only 2.7%. I told you in the last slide that historically is up to 50%. And at 1 year, and this 2.7% remained flat. It was only 2.7% at 1 year also. So although we can't make a head-to-head comparison between the dosing, in this newer study where higher dosing was used, we see a dramatically lower colectomy rate than that was described in prior studies. And what we found was that the clearance of the drug, how fast the drug moved through the body, while it didn't predict the early response, it did predict late response at week 26. And it also was a really good predictor of whether of those few patients who needed a colectomy, they had the fastest clearance at the beginning. And so what we can conclude from this, and what we'll need to study further, is that using these higher doses may be enough early on, but we may still have work to do sustaining optimal doses, higher doses, between day 7 and onward through week 26. So now we're partnering with Philip Manar at Cincinnati Children's Hospital, who has taken these models and developed dashboards that we can incorporate into our medical records. So this is showing a drug dashboard or a pharmacokinetic dashboard in the medical record that the doctors use at Stanford Healthcare and Stanford Children's Health. And it can help us predict, based on some of their labs and other factors, what dose will be optimal for a given patient, and use it at the bedside. And so we're very excited to be participating this upcoming year in a randomized controlled trial of using these dashboards versus conventional dosing, which is actually a little better than conventional dosing, but what we do currently with measuring drug levels of anti-TNF drugs for pediatric Crohn's disease. And so this is led nationally by Philip Manar at Cincinnati Children's, and then locally, the site PI is one of my colleagues and collaborators, Alka Goyle. So that's an exciting arena where we're learning to optimize dosing or get to precision dosing of biologic drugs. But another challenge is we need better ways of predicting which children with ulcerative colitis and Crohn's disease need which treatment. And for ulcerative colitis, it's which ones need biologic treatment early at diagnosis. So most children at diagnosis are treated with generally the same approach, which is steroids, which are kind of very potent anti-inflammatory drugs, but have a lot of toxicities. And so they're really not acceptable to use long-term. And then mesalamine is a very safe oral anti-inflammatory drug for the bowel, but it's only modestly effective long-term, only for about a third of patients. So because it is safe, well-tolerated oral, this is a great outcome if a patient can achieve remission on mesalamine, but we know that most aren't. And for those that don't get there, they might be exposed repeatedly to steroids or just to symptoms that are very difficult for them. And so knowing who to treat earlier with effective therapy for that person is going to be key. And I think the biology of the disease could help us predict who's going to need which therapy up front. And so if we can incorporate biology in our decision-making in the future, I think that will help us get there. So I worked with many people, but it was led by Katie Clarkson, who is who's now a pediatric gastroenterologist at Mercy Children's in Missouri, but was a trainee with me at Cincinnati. And we studied a large group of pediatric UC patients who were entered in a study with tissue at diagnosis. And we looked in their tissue specimens at diagnosis at a panel of immune genes and which genes are kind of turned on and turned off compared to controls. And so this is called a heat map, and I'm not going to dig into the details of this, but the color reflects the expression of each gene that's shown on the right, and patients are across the top. And you can see that the controls, the small number of patients on this bar all the way on the right, look very different from the ulcerative colitis patients. And there were a lot of findings in this work, but I'm going to go through one of the primary ones with you, is that the tissue gene expression, again, it's which genes are turned on and off, that was indicative of type 2 immune cell activation. So indicative of activation of a certain type of inflammatory response, certain flavor, predicted better outcomes. So if on the left here we have the diseased bowel and ulcerative colitis, on the right, the healthy lining, patients who had higher expression of cytokines such as IL-13 and IL-33 were more likely to achieve remission response on that mesalamine medicine we discussed. Whereas patients expressing high levels of the gene IL-13 receptor alpha 2, which actually blocks IL-13, were much less likely to achieve remission. And so we know there are these certain types of immune cells, these flavors of immune cells called type 2 immune cells. And we know that IL-13 and IL-33 activate these cells. And interestingly, IL-13 receptor alpha 2 blocks IL-13 and then blocks the activation of these cells. So collectively, this all sort of supports that when we promote type 2 immune cells, we promote healing, but when we block them, we inhibit healing. And so this gene expression data, we're working to see if we can use this, and you actually can incorporate this into models to get superior prediction of the likelihood of responding to therapy. And we're also very interested in studying it more to understand if there are ways to, for instance, target IL-13 receptor alpha 2 for disease treatment. So one interesting role we know that IL-13 and IL-33 have is to regulate mucus production from the lining of the intestine. And this diagram on the left shows the lining of the intestine, or the epithelium, the goblet cells in green that make mucus. And then it shows the complex mucus layer, which has two layers, an outer layer and an inner layer. And the inner layer is really pretty impervious to bacterial penetration. And so having a healthy mucus lining is important to protect from intestinal inflammation. And we know that if you have mice that lack the main component of mucus, like mucus, mice that have sort of defective mucus, they actually get colitis spontaneously. And we also know that the mucus layer is thin and there are fewer goblet cells in ulcerative colitis. So if we can figure out ways to promote mucus production, that may be helpful in the treatment of ulcerative colitis or the maintenance of remission from disease. And so to study this further, in particular, the relative role of IL-13 and IL-33, we're now moving to this cell model called organoids or mini guts. And so to demonstrate for you what these are, I show you on the left a picture of the lining of the colon under a microscope. And so I'm tracing here the lining of the colon, which is called the epithelium. It's a single layer of cells, and it forms these invaginations called crypts. And some people say they look like test tubes in a rat. And what we can do, either from animal models like mice, or even from a biopsy tissue from a colonoscopy, we can get stem cells from the tissue. And in the right, we can culture them in a dish in the right conditions to form three-dimensional structures that really start to resemble the lining of the colon, where they have these budded structures. And these buds are very similar to these crypts or invaginations. And so on the top, you see a diagram of this, and on the bottom, you see what they kind of look like in culture. And so we used these, what we call epithelial organoids, let's just call them mini guts, to study how IL-33 might promote goblet cell production and mucus production. And what we did was we cultured these organoids in a dish, as shown on the left, and added IL-33. And when we did that, we really didn't see much change. There were the same number of goblet cells. There was no change when we just added IL-33. What we found was when we added those immune cells, those type 2 immune cells, then added IL-33, we were able to get more mucus-secreting goblet cells. And through using mice that have certain genes deleted and using cells that have certain genes deleted, we were able to tease out some of the mechanism of this, and that this IL-33 cytokine was made from the lining and from fibroblasts, or cells that sort of connect things together in the bowel. And it acts on the immune cells to activate them to make IL-13, which then acts on the lining of the intestine to signal it to make more goblet cells and mucus. And it doesn't work if the lining of the bowel can't respond to IL-13, and it doesn't work if the immune cells don't produce IL-13. All those components need to be in place. And so through a better understanding of this mechanism, we can better understand this process, how the immune system is involved, and think about ways to augment it to augment the protection of the bowel by mucus in IBD. So that's not where we're leaving it with organoids. We're very excited about the future of organoids as a model for ulcerative colitis and Crohn's disease. And one of the projects we're working on that is in early stages and is led by a talented postdoctoral fellow in my lab, Babajide Ojo, is to develop organoids from ulcerative colitis patients from just a tiny, safely taken biopsy tissue, the size of a pen tip. But we can take the cells and then also grow organoids from those cells. And we can look at how they regulate genes compared to patients without inflammatory bowel disease. And we're also very interested in looking at the metabolic function, how the cells use energy, because there's evidence that that's disrupted in IBD. And we have some very interesting preliminary findings on this that hopefully we can share with you in the near future. But in this way, we can really understand how organoids derive from the disease tissue, disease patients, how they recapitulate the disease, and how we can use them to test therapies in the future, and maybe even test drugs on a patient's organoid before the patient ever sees a single dose. So here, this side, we're getting to the end here, is a overview of how I see the treatment of IBD changing in the future. Wrote this paper with actually a physician scientist that'll be joining our group, Ruben Coleman, in January. But I think in the future, we're going to take a lot of information from a patient and integrate it to determine what treatments they receive. This could include their microbiome. This could include which genes are turned on and off, as I showed you. This could include their response of their organoids to various therapies. And we're going to take their measures of their disease severity and activity and incorporate factors about their lifestyle, coping abilities, etc. This will be entered into machine learning algorithms, and that will be integrated into the electronic health record and aid us in deciding, especially as more treatments become available, which treatment is going to be the most likely to be successful, which one we should start with. But then it won't end there. And as the story we showed you in the beginning, we're going to need to monitor how that drug moves through the system of that patient, model that, feed that back to our decision support tools to optimize this therapy going forward. In this way, I hope that we'll get the right patients on the right drug, with the right dose, the right time of their disease to achieve the best outcome. So to wrap up, I'd like you to take home that inflammatory bowel disease in children is on the rise, that we have this new and exciting Center for Pediatric IBD and Celiac Disease that's providing interdisciplinary care and galvanizing researchers across Stanford. And that precision dosing of biologics can improve outcomes, deeper assessments of patient biology can help us direct treatments in the future, and intestinal organoids hold great promise as a model that comes from patients upon which we can test new treatments in the future. So I have a lot of people to acknowledge on this slide: the administrative leadership at the center, members of my laboratory, current and past. Very excited about my new collaborators at Stanford and my stalwart collaborators from the past. I also must acknowledge the support from grant funding from the National Institutes of Health, the Crohn's and Colitis Foundation, and the gift for pediatric IBD and celiac disease to Stanford by extraordinarily generous anonymous donor. And if this was of interest of you, if you would like to think about ways to support this work or pediatric IBD and celiac disease research or clinical care at Stanford, if you have ideas for collaborations, please get in touch. My email is here. I am also you can find me on Twitter, and you can direct message me there also. But thank you very much for your attention. And I'm going to stop sharing and I'll take a look at the Q&A, and it looks like we have some questions there. So we have about 10 minutes. And so I think hopefully I can get to all these questions. But if I don't get to yours, you're welcome to email me. What are the indications for J-pouch surgery and how effective is this? So J-pouch surgery, which is also called ileal pouch anal anastomosis, is a surgery for ulcerative colitis. When I mentioned colectomy, this is a surgery to help restore continuity, so that you're still going to the bathroom from your bottom as opposed to a stoma or ostomy. Generally, J-pouch surgery in children is indicated when the disease is so severe, there is a emergent risk for an impending complication like a rupture of the bowel. That's rare, thankfully. Or when medications are not working. And as we have more and more medications come online, it becomes a little trickier of deciding when is the right time for a J-pouch surgery. But this is a really, this surgical option is a very good surgical option when medical therapy is not working. And patients can have, children and adults can have outstanding quality of life with a J-pouch surgery. I don't like to call it a cure. It is trading one set of problems for perhaps a smaller set of problems. But there is a chance that people may still need medicines after J-pouch surgery. But I will also say that most patients who've had a J-pouch surgery feel good about the decision. Many wish they did it sooner. And studies indicate that they have quality of life very similar to healthy patients. So it is a good option when needed. Are there genetic markers for these conditions? Inflammatory bowel disease is a complex genetic disorder, and there are actually over 200 genes associated with risk for inflammatory bowel disease. That's how complex it is. Rarely are there very severe mutations that cause inflammatory bowel disease, usually at an extraordinarily young age, sometimes in infancy. But that's a very rare forms of inflammatory bowel disease. For these genes, these 200 genes that have variants that are associated with IBD, there's actually more people walking around, with those variants that don't have IBD than that do. So they all increase the risk a little bit. And you really need that combination of genetic risk with environmental factors, which we are very difficult to decipher, but we have some ideas as I discussed to incite sort of ongoing inflammation. But there's very active research into identifying patients at risk, particularly those who have family members with IBD, like first-degree family members. Because when you have like a sibling with IBD, then your risk goes up to about 1 in 10. And there are definitely studies that are looking at, can we prevent the onset of IBD in those patients? And that's an exciting area of research. Are there different colon cancer screening guidelines for those who have IBD? So yes, there absolutely are. When you have a higher risk of colon cancer, when you have inflammatory bowel disease that affects the colon, and typically that risk increases after having the disease for 8 years. In certain cases, when you have a concomitant liver disease, that risk goes up sooner. And so but generally, if you have IBD after 8 years of diagnosis, it's recommended that you have screening colonoscopies at regular intervals. And that depends a little bit about what you find on the first screening colonoscopy, but at least every 2 to 3 years. We have a solution to assure drug levels. Who can we contact to explain our solution? Well, you're welcome to send me an email. That was on my last slide, and you can catch it in the recording if it passed you by. Steroids are not safe to use long-term. How is long-term defined? It's an excellent question. Generally, I will personally, and every patient is a little different. So with that caveat, Personally, I try to use as little steroid as possible. I consistently seek ways to avoid using steroids, but when I do need them, I usually start a taper for no more than 2 to 3 months max. And if we're needing to do it again in the near future, we need a different ongoing treatment plan. Usually if I tell my trainees, if a patient is needing a course of steroids every year, that is too much. Is there a role for probiotics as a complementary therapy? So, probiotics, right, is the concept of adding good bacteria to the bowel. And I'm a little disappointed to have to tell you that there's no compelling evidence that any current commercial probiotics really change the trajectory of inflammatory bowel disease. I think there may be a future for probiotics. We may have to give more than just bacteria. We may have to give the food for bacteria or prebiotics at the same time. So I think we just need more research in this area. But I don't think most commercially available probiotics, they're certainly not in most patients. They won't be harmful, but there's really not compelling evidence that they increase rates of remission. So these were all fantastic questions. Thanks for your questions. Thanks for your attention. I think we got to all of them. I've really enjoyed this discussion. Thank you all for your interest.
Thank you, Dr. Rosen, for sharing this great information. And thanks to our audience for joining us and for the great questions. If you'd like additional information or resources, please contact the Stanford Health Library. We hope you'll join us for our next lecture. Good night.